Good afternoon. I'm Silvia Salvatore. I'm a pediatric gastroenterologist. I worked at the University of Insubria in Varese, Italy, and I will talk about gastroesophageal reflux and cow's milk allergy. And I will focus on infants. Our group just published a paper about the link between cow's milk allergy and gastroesophageal reflux disease. That is still a dilemma in infants, and we will try to solve. So we will go through the prevalence, the pathogenesis, the clinical presentation, the literature data, and then we propose a stepwise approach with education and nutrition first. What about the prevalence? Well, you probably know that about 3 in every 100 infants suffers from cow's milk protein allergy. And cow's milk protein allergy can present in many different ways, including the gastrointestinal symptoms. What about regurgitation? 1 out of 4, up to 1 out of 2 of infants suffers from infantile regurgitation, particularly in the first months of life. And that's clear from every part of the world. Many studies showed this kind of figure. And also, many infants suffers from combined gastrointestinal manifestation like constipation and colic. About 4 out of 10 infants. But just 1 or up to 5 infants in 10 infants suffers from gastroesophageal reflux disease. And about colic, the literature shows that 5 to 10% of infants has cow's milk allergy or gastroesophageal reflux disease behind the colic manifestation. So if we put together all the data from the studies published from 1994 to 2020, it appears that 16 to 56% of patients have combined gastroesophageal reflux manifestation and cow's milk allergy. So it's a wide range of prevalence. Why it happens? What about the pathogenesis that links cow's milk allergy to gastrointestinal symptoms? And particularly, what about cow's milk allergy and reflux? It's a complex mechanism, a multifactorial immune mechanism that involve lymphocytes, mast cells, eosinophils, cytokines like interleukin-4, 5, 13, and for particular kind of manifestations that include eosinophilic and gastric manifestation, the mechanism is more linked to non-IgA mediated factors. Ravelli published in 2001 an important paper highlighting that in patients with cow's milk allergy, vomiting can be caused by gastric dysmotility problem. And in the figure, you can see the difference between non-atopic subjects and atopic subjects showing more frequently bradygastria and tachygastria, particularly after cow's milk protein challenge. This elegant paper from a group from UK also pointed out that the dysmotility problem is related to a connection between narrow immune system mediated by mast cells that cause a disturbed gastric myoelectrical activity and dyspeptic symptoms. And in the arrows, you can see that in atopic children, eosinophils and mast cells migrates next to nerve fibers and releasing tryptase cause abnormal gastric motility after a few minutes of exposure to allergen. And what about the difference between gastroesophageal reflux and gastroesophageal reflux disease? This is a spectrum, and you can have easy situation, clinical presentation, like in infants with just regurgitation, happy spitters. And on the other hand, another easy distinction with patients presenting with heartburn or esophagitis. And it's clear that in the two parts of the spectrum, you can reassure the patients and the parents or use PPI medication. But what about in between? That is a gray zone in which the patient can present crying, sleeping, or behavioral problems, or respiratory symptoms, or back arching. And it's not just caused by reflux or not just caused by cow's milk allergy, but can be caused by many other different conditions. And this is still a challenge. What can be behind? We have to exclude warning signs and alarm symptoms, looking at the history of the patients and the combined presentation and also physical examination. And anytime you find something that is abnormal about growth or milestones or abdominal examination or onset of symptoms or interaction, or if you have tests, you have to exclude organic disorders. But is this so easy? Actually, no, because you have a wide range of overlapping presentation, and the distinction is still very difficult. Because as you can see, you can have many different general gastrointestinal presentation can be shared, but to different conditions. And also, functional gastrointestinal disorders can present in a similar way because there is an overlap, age, there is no specific symptoms, but frequent and non-IgE-mediated mechanism, and possible association, and confounding response to extensive hydrolyzed formula, not mediated by immune mechanism, by gastric emptying effect. And also, you have to properly diagnose cow's milk allergy, because otherwise it can predispose to more prevalence of functional gastrointestinal disorders later on in life in children. So in the first months of life, the distinction is still challenging. And it's not just between gastroesophageal reflux disease, cow's milk allergy, and functional gastrointestinal disorders, because there is a fourth wheel about eosinophilic esophagitis. And many mechanisms are between these different presentations that will not go in details, but you can find in our paper all the details about the different presentations. So going to the literature data, starting from an old paper, quite important, showing that conservative therapy, modifying diet with extensive hydrolyzed formula, thickened formula, avoid overfeeding, control position, and avoid passive smoking, you can have a significant improvement of regurgitation, crying, and arching after 2 weeks. So try to be conservative regarding infants with gastroesophageal reflux presentation, and try not to use medications, particularly in infants with crying, because crying is not exactly pain, and pain is not exactly reflux, and particularly is not often related to acid. There's no correlation between crying time, as you can see from the figure on your left, and acid reflux time percentage during the day. A systematic review demonstrates that there is no effect of proton pump inhibitors on crying and irritability in infants overall, and just 5 to 10% of infants need this kind of medication. And we also show that about half of the total number of distress episodes were temporarily linked with GERD, demonstrated by impedance, esophageal impedance monitoring. And the pain measured by flux score was even more when non-acid reflux was behind this association. So use PPI, proton pump inhibitors in crying in infants only when you have a proven correlation with acid. Coming back to the association and the number that we had from the literature, why is the range is so wide? And when we can think about this combined problem, when you have persisting symptoms, both in breast and formula-fed infants, but negative IgE, if you have negative IgE, you have no predictive test or biomarker, and you have various percentage of response to diet and challenge. And even more, you have heterogeneity in studies about a population recruited, diagnosis, and follow-up criteria and data. Is there something new? Some breaking news? There's this very nice paper published by Tahero Mari in 2020 in Journal of Pediatric Gastroenterology and Nutrition. And you can see that they used many different tests to try to differentiate infants with persisting distress, with non-IgE mediated cow's milk protein allergy or a reflux disease, making 3 phases of the studies, 2 monitoring with esophageal impedance, 2 challenges. And what happens is that they cannot differentiate the infants with cow's milk allergy and gastroesophageal reflux disease. We don't have any clinical marker, we don't have any biomarker, we don't have any predictive impedance parameters that can differentiate. So again, what we have to do is elimination diet and challenge, because patients with chronic gastrointestinal manifestation are more likely to have a non-IgE mediated mechanism. Is there something else? Well, a group of experts tried to create a score that is called COMIS, Cow's Milk Symptom Score Awareness, considering 5 items about crying, regurgitation, kind of stools, skin symptoms, and respiratory symptoms, and the score above 12. A number of studies show a reduction of total COMIS and regurgitation with extensive hydrolysis formula in infants with both positive and negative cow's milk challenge. So you can use this instrument, this tool, to identify infants that can benefit from a diet with extensive hydrolysis formula. What we propose is a stepwise approach for infants with the persisting regurgitation, vomiting, and crying, starting to exclude alarm signs, and then going to check feeding, position, and interaction, avoiding overfeeding and extra fluid, correct position, reassure and reinforce positive interaction, and promote breastfeeding. If symptoms persist, you can start a diet intervention for 2-4 weeks. If you have signs of allergy, you will start with the cow's milk-free diet. If you don't have signs of allergy, but just regurgitation, you can start with the thickening formula, if not breastfed. And if symptoms persist, you can consider a short course of alginate. And only if still symptoms persist, that there will be a very minority of infants, you think about testing for gastroesophageal reflux disease and esophagitis. And if you have a negative test, you have to reconsider differential diagnosis. Why alginate? Because we demonstrate with the 48 hours pH impedance in a group of infants that alginate can reduce symptoms like crying, fascinance, cough, regurgitation, and total episodes of reflux, acid, non-acid, proximal reflux, and bolus exposure index. So again, try to use this stepwise approach as a practical approach for infants with persisting symptoms and consider tests for reflux disease just at the end of the stepwise. Education and nutrition first, just to promote breastfeeding and continue to promote, because it's the best functional personalized food, both for nutritional factors, for immune properties, for motility factors. Never stop breastfeeding, even if your infant has cow's milk allergy, gastroesophageal reflux, or gastroesophageal reflux disease. And if you cannot use breastfeeding, what else? If an infant with persisting regurgitation, you can think about starting a thickened infant formula. And in this review, we demonstrate that the number of infants with no regurgitation increase with the thickened infant formula. You halve the number of regurgitation per day, and you improve your weight gain. No data show that one particular thickening agent is more clinically effective than another, but clearly show that you have to use a little amount of thickened agent. So commercial formulas much more than homemade formula. And then extensive hydrolyzed formula reduce regurgitation in infants with positive and negative challenge, with a significant improvement after 2 to 4 weeks. The highest reduction you will see in those with confirmed cow's milk protein allergy, but regurgitation reduced in all infants. What does it mean? That it's also a motility effect, and you have even a better improvement with the thickened extensive hydrolyzed formula in the infants with negative challenge. So try to reduce acid inhibitors. That's the message, one of the key message, because it you cannot predict which infants will have acid GERD disease. You can also have non-acid reflux causing pain and symptoms. You have other cause than reflux. And because it's an increasing impressive use of PPI that is not justified by diagnosis, and you have a significant increase of adverse events like double infections, possible increase the rate of allergy, disturb microbiota, and others. So to conclude, you can consider personalized treatment pyramid for GERD and GERD disease, starting in infants with simple regurgitation to infants with persisting symptoms, secondary reflux disease, proven reflux disease, and resistant. And it's based on parental reassurance and education if you have simple regurgitation in infants. If you have persistent symptoms, consider diet intervention with cow's milk-free diet, thickened formula, possible alginate. If you have secondary reflux disease, treat primary disorders. And then if you have proven reflux disease, use just in this minority of cases, proton pump inhibitors. If you have an acid correlation, possible alginate if you have non-acid reflux disease, and then optimize PPI. Thank you very much for your attention.